Hello, everyone. You're all welcome to the second edition of the Archon Specialist Breast Series. You're welcome, Dr. Vitalis. I can see Dr. Charles Okonna. Good evening, everybody, and you're all welcome.
You're welcome. Good evening, Chief. Nice to be here.
So it's just about 2 minutes to 5 o'clock, and we intend to commence the meeting by 5 p.m. on the dot.
Hello, Zubair. Can you still see my screen?
Yes, Prof, I can see your screen.
All right. Okay. Thank you.
Good evening once again, and you're all welcome to the second session of the Archon Breast Cancer Expert Series. Today's topic is on optimal diagnosis, the bedrock of breast cancer management, and this will be delivered by Professor Peola Soeton Samaila. I'll go ahead to briefly read the citation of, sorry, let me turn on my video. I'll go ahead to briefly read the citation of our guest professor today. So Professor Samaila, who I have the honor to introduce as my teacher, is a professor of pathology and Ahmad Bello University Teaching Hospital, Zaria. She has a specialization in breast, gynecological, and dermatopathology. She graduated from Ahmad Bello University, Zaria, where she obtained her Bachelor of Medicine and Surgery degree and subsequently completed her residency training in anatomical pathology. She is a fellow of the National Postgraduate Medical College, Nigeria, and College of Pathologists, East, Central, and Southern Africa. Professor Samaila pioneered dermatopathology specialty practice in Nigeria and offered a subspecialty dermatology textbook using 100% in-country practice materials after observing the dearth of dermatopathology textbooks that focuses on skin of color. He has authored and co-authored over 150 peer-reviewed articles in high-impact journals, in addition to over 70 papers presented at in-country and international conferences. She was a visiting international fellow at the Women and Infant Hospital of Rhode Island, Alpert Medical School of Brown University, USA, where she bagged a certificate in women pathology. She is the recipient of the Best Case Presentation Salzburg OMI Seminars Award, among several scholarship and travel grant awards. She is also a cancer epidemiologist and has published a booklet on the cancer trends as seen in Zaria Cancer Registry. She is a fellow of the Academy of Medicine Specialties and Nigerian Academy of Medicine. She was a pioneer deputy dean, Faculty of Basic Clinical Sciences, College of Medical Sciences, Ahmadu Bello University, and immediate post-chairman of the College of Nigerian Pathologists, Kaduna State. At present, she chairs the Education Committee of the West African Division of International Academy of Pathology. Professor Samaila, please, the stage is yours, ma'am. Hello?
Thank you very much, Dr. Zubair, for your kind introduction. Thank you. So I will be talking about optimal diagnosis, the bedrock of breast cancer management. I hope everyone can see my screen. Right. So apparently everybody is an expert on breast cancer diagnosis and management now, because you see quite a number of foundations and everybody talking about breast, except the true experts who are confounded and humbled by the heterogeneity of breast cancer. So highlights of breast cancer: it is the most common female cancer with a 2.3 million new cases and 0.68 million deaths. In terms of molecular classification, we'll quickly remind ourselves that we have the lumina-like breast carcinoma, which has some hormone receptors, lumina A, lumina B, the HER2 enriched, the basal-like carcinoma, triple negative. And I must quickly say here that basal-like carcinoma and triple negative carcinoma, many times people use them interchangeably, but really they are not the same thing. They are not synonymous. There's at least 30% discordance between the two of them. We also have other classification like normal breast-like, which is the unclassified breast cancer, the Claudin low, quadruple negative, which is associated with androgen receptor negativity. And of course, the new kid on the block is the PD-L1 positive breast cancer. That's programmed cell death ligand positive breast cancer. This group of breast cancers are amenable to immunotherapy. So just a tabular representation of a molecular classification of breast cancer. Now, if you look in depth into They account for over 75%. But the new classification does not put in ductal, it just says invasive carcinoma, but everybody knows that that is a ductal carcinoma. So the second thing you want to talk about is the tumor stage. And the tumor stage at pathology level means that you are going to do a pathological staging, which recognizes, I don't know if you can see my pointer, which recognizes the presence of lymph nodes. But the pathology is constrained in talking about pathological staging when the surgeon has not submitted lymph nodes and when the pathologist cannot access lymph node when he is doing his cutoff at the crossing table. There are no lymph nodes, so you cannot give an adequate pathological staging of that tumor. Again, you cannot give pathological staging depending on the type of biopsy that you have been sent. You have a true cut biopsy and radio-oncologist wants you to stage. What are you staging? You can't stage. So, and the third thing is the tumor grade. Now, some morphological tools have been provided. Some morphological tools have been provided for staging for breast cancer diagnosis. And basically, we're talking about the Nottingham grading system, which has been modified from the Scarf Richardson Bloom. And this grading system determines the tumor aggressiveness. It takes into cognizance 3 parameters of tubule formation, mitotic activity, and cellular pleomorphism. So you're supposed to look at the slide and say, what is the percentage of tubule formation? Is it less than 50%? Is it 50 to 75%? Is it more than 75%? And you give a value to it from 1 to 3. Mitotic activity, less than 5, 7 to 15. More than 15, you give a value. Cellular pleomorphism ranging from mild to moderate to severe pleomorphism or marked pleomorphism of the nucleus. So you have a grade of grade 1, grade 2, grade 3. And a 1 tumor is going to be 1 to 3, grade 2 is 4 to 6, and grade 3 is 7 to 9. So this is actually something that should be reproducible. Then, of course, there's a Nottingham Prognostic Index, which predicts long-term survival. And that long-term survival was pegged at 5 years, but we now have it going as high as 10 years. You calculate the Nottingham Prognostic Index using the tumor size in centimeters, number of lymph nodes, and the tumor grade. And this, with a factor of 0.2, gives you the prognostic index. The higher the index, the lower the prognostic outcome. So a combination of Nottingham grading system and Nottingham prognostic index is actually needed in the clinical management of patients for adjuvant therapy. But more often than not, this is not given by the pathologist. Slide is stuck in space. Slide not moving. Sorry, I don't know, just slide not moving. Okay. So what's the relevance of this grading? I've already alluded to the fact that it is more objective and it is reproducible. And the Nottingham Prognostic Index has been extensively validated and it is predictable. It's useful in predicting the prognostic outcome. And prognostic determinants are histologic grade, lymph node status, and tumor size. But of all, the most important indicator of outcome because it predicts the tumor behavior rather than the tumor size. Meaning you can have a histologic grade of 3 with a small size tumor, and you can have a huge size tumor that is grade 1. So you see that is the histologic grade that is the most important parameter to focus on rather than the tumor size. Now again, histological types. Some histological types have some favorable outcome. These histological types that have been associated with favorable outcome include mucinous variants, papillary, adenoid-cystic. As a matter of fact, adenoid-cystic variant was added in 2020, We have cribriform and tubular. Breast cancer histological types that are associated with poor outcome include the invasive micropapillary carcinoma, invasive apocrine adenocarcinoma, and of course, metaplastic carcinoma. There are some with intermediate outcome are your early invasive lobular carcinoma and the invasive ductal carcinoma. So what should a pathology report have? It should talk about the histological type and tumor grade. If there's DCIS there, and you need to grade the DCIS, is it low or high? High is often associated with comedonal necrosis, presence of lymph node, you want to mention the presence of lymph node, and the pathological stage. But all of this is limited by the biopsy type. Is it a true cut biopsy? You cannot give an adequate staging. Is it core? You can still not do that. It's only with mastectomy that you can truly stage this lesion. Stereotactic biopsies, which is ultrasound guided biopsy, you can actually not stage this tumor because you're not having the full complement of the biopsy. So tumor characteristic determinants, I've said histological type, the grade, and the pathological stage. So is optimal breast cancer diagnosis achievable in a current practice setting? I don't know what the response will be. If this was a live audience, I would have been very curious as to know what the response will be. Is this really achievable in a current practice setting? I want to believe that yes, it is achievable. But for it to be achievable, we have to learn how to handle our tissues properly. And the idea said that correct tissue handling is pivotal in all histopathology diagnosis and detrimental in breast cancer diagnosis, particularly when poorly done. And more often than not, breast tissue is poorly handled, and the poor handling starts from the operation room. So for you to handle this tissue properly, what are the things that are needed? We refer to them as pre-analytical components, analytical, and post-analytical. I think I'll dwell more on the pre-analytical because this is what affects our clients, whereas the analytical and post-analytical is purely a pathology problem. What are these pre-analytical problems? We talk about the specimen type, acquisition of the specimen, type of fixation, transportation, as well as processing. So what is the type of tissue that you are sending to the pathologist? Is it a true cut? Is it an incisional biopsy, excisional, needle cut, mastectomy? The smaller the biopsy is, the more that biopsy is prone to interpretational error. So many times I've seen true cut biopsy that the surgeon is so happy with himself that he sends true cut biopsy. Meanwhile, all he has sent is fat. And he's breathing down our neck that, oh, there's a tumor, there's a tumor. Why can't you tell me there's a tumor? I can't tell you there's a tumor because I've not seen tumor. Until I see tumor, I was able to tell you that there's a tumor there. What about the tissue acquisition time to fixation? So this is broken down into two. The warm and the cold ischemic time. We are aware that there isn't much you can do about the warm ischemic time because this is the time it takes for the surgeon to do the procedure and then completely devoid the tissue of blood supply. We now enter into the cold ischemic time. But we can't reduce the cold ischemic time. And our recommendation is that the cold ischemic time, that is when the tissue is completely devoid of blood supply, should be reduced to 1 hour recommendation. So for this is a Helican task. 10% formalin, 10% neutral buffered formalin is the recommendation. If you cannot get 10% neutral buffered formalin, please use 10% formalin. We have people using bleach, they are using soap, they are using detergent, they just pour water and mix the detergent and send it into the laboratory that we're going to perform some magic. There's no magic in pathology. When you send these tissues in wrong fixative, what we end up with is necrotic tissue. Can you hear me, please? Am I talking to myself?
We're hearing you.
Yes, ma'am.
Yes, Prof, we can hear you clearly.
Thank you
We are
very
hearing
much.
clearly. Thank you.
We're
Yeah.
hearing you, ma. Please carry on. We're hearing you
Thank
very
you so
clear.
much. All right.
Thank
So
you very much.
we
We
want
are
you to
hearing
be putting the tissue in proper fixative. If you do not know how to access this fixative, please go to the nearest pathology lab. Many times the pathology lab provide this fixative to all relevant departments. And what we expect is as soon as this fixative is finishing in your department, please request for more. Don't add water to dilute it. Once you dilute it, it's no longer 10% formalin. It's no longer 10% neutral buffered formalin. What about the duration of fixation? Duration of fixation is particularly important. If you want to assay for estrogen receptor and progesterone receptor, the minimum duration is 6 hours, whereas the maximum is 72 hours. For HER2, 6 hours to 48 hours. But you have colleagues taking a sample now, and then 5 hours later, they want a result. You are not even talking about the tissue processing before you even go to immunohistochemistry. What about the volume of fixative to tissue? The tissue should be 1, and the volume of fixative should be 5 to 20, meaning that the tissue should be swimming in the fixative. But we are having people forcing tissue into injection bottle. You know, you can do a surgery of 250,000, and then you go and look for a bottle that has been discarded somewhere and force the specimen inside. That's what is happening. We want containers to have open, wide bore so that you can actually put your hand inside. Many times, pathologists have to break these containers and injure themselves in the process. Who sends these biopsies to the laboratory? Who should send it to the laboratory? Now we have people practicing correctly when they're in teaching hospitals, public hospitals. But from private setting, the same people, when they go to private setting, it's as if they just throw some brain cells away and start doing some awful things. So you expect that when you do a mastectomy, don't just give it to the patient's relative to go and do what they want to do with it. It is part of your responsibility to educate them that, look, we've removed it, but we still need to do some other things on this biopsy, on this specimen. Don't go and throw it away, because when you give it to patients, patients are not educated enough. Many of them are not educated enough. They go and bury it that, oh, they have seen the evil has been removed from the body, and they go and bury it. So you need to actually start charging them alongside with the surgery, because once you charge them for surgery, you don't remember the pathological fee. Put it there so that they know that, look, we still have to go ahead and do this procedure. And of course, this tissue undergoes processing, and the tissue itself is supposed to undergo some tissue quality index to know whether it is fit for processing, particularly when you have sent it in bleach or kerosene or petrol, or even zobo. We see all sorts of things. Okay, so fixation, tissue fixation. Why are you fixing the tissue? Because it preserves the tissue proteins and it stabilizes them to prevent further changes or deterioration. We don't want autolysis during tissue processing, and then you have a good staining outcome. So fixative people, we want you to use neutral buffered formalin. So to summarize what pre-analytical is about, we say correct tissue handling for optimal diagnosis starts from the operating room. And what we want is that you reduce the ischemic time, hold the ischemic time to at least 1 hour. Ischemic time affects test interpretation because of labile micromolecule variation. Now, when you keep the specimen on fixed, and you put it in the refrigerator, in the fridge, in the freezer, it actually uses expression of ER. Whereas if you don't refrigerate it and you keep it outside, it stands a better chance of still keeping some of those labile micromolecules. What about the performance of 10% formaldehyde to or formalin to neutral buffered? Not too different. So that's why I've said if you cannot get neutral buffered formalin, you can use your 10%. But that laboratory pathology laboratory also requires a pH meter that can continue to monitor the pH of the fixative and maintain it at 7.2. And of course, we don't want to have fixation of less than 6 hours because you will not be able to determine the ER positivity. So there's also a pathology requisition form that comes along when you are sending your biopsies. Who should fill this requisition form? Many times we just leave it to house officers. House officers are supposed to be guided. You're supposed to give them the information. So you send patients biodata, you put the name there. Also, males have breast cancer. So we don't want to assume that is a female you mean. You can put a female name there, and then you inadvertently put a male there. We start wondering. We don't have physician information. We don't have the date of the procedure. No clinical detail whatsoever. There is no preliminary diagnosis. In fact, I've been seeing some wonderful preliminary diagnosis. Mitotically active breast disease. There's no dictionary for mitotically active breast disease. You don't talk about the type of specimen, which part of the breast, which side of the breast, is it left, is it right, which quadrant? All of these are information that is needed and that guides the pathologist. The pathologist does not have a crystal ball to look at this thing. As a matter of fact, I've been advocating for a long time that every time the surgeon, the clinicians, the physicians want to go into the laboratory, you are supposed to share your operation list with the pathology department so that they get ready for your specimen. Nobody is doing that. What about the type of fixative? How long have you been using this fixative? Is it due for change? So you don't give a previous histology. Now it's only a consensus pathologist that says, oh, I've come across this name before. Can I just go and check the system? So you're supposed to give, if there's been a previous cytology, a fine needle aspiration, a mammogram, you're supposed to attach to this biopsy you are sending. And please stop bisecting the specimen, giving one to pathologist A and giving the second to pathologist B. All the pathologists may be in one quadrant that you have bisected and it's not to the other one. So you now say, oh, this pathologist doesn't know what he or she is doing. No, you are entitled to second opinion if you are not happy with the first diagnosis, but give all of the tissue to one person to look at. So poor test accuracy and errors in pathologic and histologic findings are actually directly linked to poor tissue handling. And this has been documented in quite a number of our studies. There is no precision you give is as good as the diagnosis the pathologist is going to give you. It's like what they say, garbage in, garbage out, when you are putting data into the computer. So why do we need to determine the immunohistoreactivity? Well, the straight for breast cancer. Well, how do we optimize these decisions? How do we optimize them? At present, can there be seamless, detailed clinical information without us calling the clinicians that, when did you take it, where did you take it from? Can there be morphological diagnosis and immunohistochemical testing at the same time? We're able to do this for a while in Zaria, where you have morphologic diagnosis and then you do the immuno. Now that the cost of antibody has gone up, you have to wait, you make the diagnosis. When patient comes, you now say, go and do immunohistochemistry. I think there are better options to this. Why not just have a flat rate for your breast lesions? Something like what you are having with NHIS. It's not everybody that is contributing in NHIS that is benefiting at the end of the day. And the same way, you look at it the same way that somebody brings a small biopsy to pathology laboratory, he pays the flat rate, and somebody brings the entire human body and he still pays the flat rate. So kind of you balance out. I think we need to start exploring the idea that at the point of surgery, the clinicians should just bill the patients that you are doing immunohistochemistry. And if the patient doesn't do immunohistochemistry, so be it. But that time lag of you have done morphology, you've given a histopathologic diagnosis, and then patient comes. Patient has to go and look for money for immunohistochemistry. This delay optimization of breast diagnosis, because without the immuno report, the patient cannot access proper treatment. So, an optimizing treatment options in diagnosis, availability of high quality tumor marker tests with proven analytical validity and clinical utility is crucial, or is critical in this era of precision medicine. So we need to do immunohistochemistry, and we shouldn't be delaying in doing it. Biomarker changes with prognostic implications occurred in all breast cancer subtypes, particularly in hormone negative or HER2 negative breast cancers. So we need to do this immunohistochemistry. So these are the range of immunohistochemical antibodies or biomarkers that you should at least have in a pathology laboratory. If you cannot have all the complements, you should have ER, PR, HER2. Those are the most basic of them all. So, but it becomes a challenge again. The surgeon does a mastectomy, he doesn't even know which breast he has done. And we're going to start running into trouble now, because gender issue has not caught up with us in Nigeria, but very soon we're going to be having issues. Or is it a man, is it a woman? So it's not enough to have the immunohistochemical antibodies, but you must also be able to interpret it. Where is it supposed to stay? Every brown coloration is not necessarily an immunological response, because even brown coloration can occur with your formalin pigment, and that's why we're advocating for neutral buffered formalin, so that the formalin pigment does not deposit within the tissue. So when you talk about accurate immunoreactivity interpretation, for your ER and PR, it's supposed to be nuclear. So what she's supposed to stain is the nucleus, whereas your HER2 is membranous and is supposed to stain the membrane. So that is the accurate interpretation. But so many other things can affect this accurate interpretation of the immunoreaction. Now, people, immunohistochemistry is an adjunct to thorough histological evaluation. It's never a substitute in tumor diagnosis. Because this is, I say, everybody, once you get a tissue, you say, oh, immunohistochemistry. If you have not identified the tumor, what immunohistochemistry are you going to be asking for? You have to do a thorough evaluation of the histology before you can request for immuno. And I guess this is particularly important for other types of pathological diagnosis, tissue diagnosis, where you have not looked at the tissue, and many times the radio-oncologists are breathing down the necks of the pathologists that do immuno for what? So analyticals in breast cancer, we'll talk about the protocols, the SOP you are using, the reagents validation, what type of antibody are you using? Is it clones? Control selection. You must use appropriate sample for control, appropriate positive samples for control. In test selection, you have to have looked at the histology first, then the H&E stain slide that you are going to select for the IHC. And the scientist that is going to run it, is he competent enough? Has he been trained? Has he undergone some training? Many laboratories in Nigeria are doing manual processing of immuno. We're supposed to have been able to establish some, we started establishing some collaboration with Roche to give us this automated machines. I don't know whether it's dollar that has chased them or something else. So your laboratory should also have certification, whether it's for the laboratory and the personnel. Then you must also have internal and external quality control schemes in place. Post-analytical, I've said control must always be positive, and your controllers and tests must always be on the same slide. This is the gold standard. I've seen some laboratories where the control is on a different slide and the test is on a different slide. This is purely not acceptable. It must be on the same slide. Of course, result interpretation must also be done using standard protocol and guideline, taking into cognizance the staining pattern, the internal control, whether they are positive or negative. And if your internal control is positive, why is it negative? Then we'll talk about the pathologist's competency and his consistency in interpreting the immuno every time he sees the same thing. And then at their inter and intra-observer error elimination, we talk about quality assurance and pathology report using standard protocol. That would be the post-analytical. So what about prognostic versus predictive indicators in breast cancers? Our prognostic indicators are those data that you identify at the time of morphological diagnosis that relates or predict the clinical outcome. This is completely unrelated to adjuvant therapy. So those prognostic indicators are the histological type, the grade of the tumor. Whereas, and then of course the immunoreaction, whether it is ER positive, PR positive, or HER2 positive. Whereas your predictive indicators are those related to the data related to the degree or extent of hormonal therapy, if you've given some chemotherapy, adjuvant therapy, those are the predictive indicators. Of quality testing in breast cancer. One, accurate determination of biomarkers is essential for proper management of breast cancer. Pathological and molecular heterogeneity within similar group of breast tumors with different outcome in individual patients. We do know that ER, PR, and HER2 are important prognostic and predictive markers. And then, of course, we've talked about those that are endocrine, that will require endocrine therapy and targeted therapy when I talked about the molecular classification. So what's the value of ER testing in breast cancer? We know that ER is a weak prognostic marker of clinical outcome with therapy. Estrogen receptor expression is seen in 2/3 of breast cancer and is influenced by tumor histology and grade. ER has clinical, can you hear me? Oh, hello? Am I speaking to myself?
Yes, yes, we can hear you.
We can hear you, ma. Ma, we're hearing you clearly.
We can hear you.
Yeah, we can hear. Thank you.
ER has clinical utility in identifying patients that will benefit from endocrine therapy. Endocrine therapy reducing risk of invasive cancer, particularly in patients that have DCIS. When they have florid DCIS, you do IHC and ER positivity. I believe that there's a treatment protocol for this category of patients with radio-oncology. ER positivity is also influenced by race, age, screening, and birth rate. And higher ER positivity is usually seen in postmenopausal females. The ASCO guideline for scoring ER, we'll talk about positive. So the positive ER, unlike when we first started, these things keeps undergoing different guidelines, and it's sometimes very difficult to keep up with these changes, but we need to keep up with them. So positive now is that once over 10% of cells demonstrate nuclear positivity, when you do your IHC, that's positive ER. But you're also supposed to specify the percentage of cells with nuclear positivity. You're supposed to talk about the intensity of staining, whether it's weak, moderate, intermediate, or strong. What does low positivity mean? Low positivity means that there is a staining of between 1 to 10%. So you need to specify. And then you also need to talk about the average intensity of staining, whether it's weak, moderate, or strong. You must mention the status of the internal control for low positivity ER. And then also talk about if the internal control is absent or not. I have asked some radio-oncologists that when we go through the trouble of talking about low positivity, what do they do? Do they offer treatment? Somebody told me that no, it's not going to treat the patient. It's not going to offer endocrine therapy. So I said, why am I wasting my time telling you about low positivity? Perhaps the audience will be able to answer me today. Since it's your association, why will I go through the trouble as a pathologist to tell you that this is low ER positivity and you're not going to offer any treatment? The protocol for the pathologist is that when you do have low ER positivity, you just put a caveat there that you do not know the benefits of endocrine therapy. You don't know, but you still want to try it on the patients. Who knows whether it's going to work or not? But you put that caveat there. What does negative results mean? Negative result means less than 1%. And then again, you still must talk about the internal control present and whether they are staining as expected and whether the internal controls are absent or not. And if there are other issues there, you state. You have instances where it cannot be determined, your staining cannot be determined. And where these instances of indeterminate staining is when the tissue has not been well fixed. So you have this gut feeling that this tissue will have been positive, and you are seeing the brown coloration somewhere else. But even the people making the immunomarker now, they know that we are always looking for brown. They are changing their colors. So for those of us that are colorblind, it may be a challenge. So if it cannot be determined, you also have to talk about the internal control as well, whether the internal control, there's no reactivity in the tumor cells anymore, or is also affecting the internal control. If it's affecting the internal control, it means that you really have issues with your fixation. So it means that the surgeon or the physicians have not used the right fixative. Now, this is what we use commonly, the all-red scoring. What does all-red scoring do for ER? It means that you look at the proportion of cells that are positive. What is the percentage of cells that are positive? And then the intensity of staining. The percentage of scores, which is the proportion score, is graded into 5, 0 to 5, while the intensity is graded into 0 to 3. So 0 means that there's no staining at all. And then your 1 is less than 1%, 1 to 10, 11 to 33%, 34 to 66, and over 67%. And you give the appropriate score. And intensity is 0 to, I'm sorry, this should have been 2. This intermediate is 2. I apologize profusely for that. This should be 2. So how do you now interpret? Say you have proportionate cell of 3, that is 11 to 33, and then you have some intermediate intensity. So 3 plus 2 is a score of 5/8, because the overall total score is 8. So 5/8 is positive. Any score that is 3 and above is deemed positive, while 0 to 2 is negative. That is how you interpret all red scoring for ER and PR, the same protocol that I use for PR, because both of them are nuclear staining. Still in reporting ER, I earlier on said that ER, African American, I said is affected by race. African American women die more frequently from ER positive breast cancer than European American women. ER positive and HER2 negative disease have highest 5-year survival rates, and low ER positive tumors actually have molecular properties similar to triple negative breast cancers. So I've talked about the all-red score and the threshold that any score of above 2, that's 3, is positive, and below 2 is negative. And the ER low positive breast cancers, you need to comment on the positivity rate, particularly in invasive breast cancer, not when you are dealing with DCIS. So you can also have all the places where I've mentioned others. You have to mention technical issues like artifacts, crushing, edge artifacts, and dumping of the immunoreagents. Then, of course, the interpretation. You have to evaluate the concordance of that tumor. That's the histological type and grade. It should correlate with your immunointerpretation. You have a grade 3 tumor, and you are saying your grade 3 tumor is just ER positive. What about the HER2? You should be able to correlate the two together. So what is the value of PR testing in breast cancer? PR is an upregulated target gene of the estrogen receptor, and it's a valuable prognostic marker in breast cancer. Its expression is strongly dependent on estrogen, and it is seen in over 50% of ER-positive breast cancer. More often than not, PR-positive tumor cells are often ER-positive. However, However, there are instances where you have ER negative and PR, very, very small, insignificant subset. You have PR positive tumors and ER negative tumors. But when you encounter this scenario, you have to pause. Is it a false negative ER or a false positive PR? If you run the test again and the PR is positive, then you have to report it as such, that this is a small subset of patients that will have positive PR and negative ER. Now, low PR in ER positive breast cancer is associated with more proliferative and aggressive disease, poorer prognosis, and recurrence. And that's where you need to be sure. So, but PR positive and ER positive breast cancers have more favorable clinical pathological parameters and prognosis. Again, a reminder that immunohistochemistry is an adjunct to thorough histological evaluation and not a substitute in tumor diagnosis. There is no crystal ball in pathology, there is no juju, there is no voodoo that we're doing. The more the information you render to the pathologist, the more you help the pathologist in arriving at a diagnosis that helps you and helps the patient. What is the role of HER2 in breast cancer diagnosis? HER2 is either amplified or overexpressed in 15 to 20% of breast cancers, and about 40,000 to 50,000 new cases of HER2 positive breast cancer is diagnosed annually. HER2 expression is associated with aggressive disease, grade 3. So you have a grade 3 tumor that is HER2 negative, you have to start wondering. It's also associated with recurrence and higher mortality in the absence of adjuvant therapy. HER2 testing is a useful marker for therapeutic decision-making in breast cancer management and is also a strong predictive factor. The 2018 updated ASCO-CAP HER2 testing guideline increased HER2 negative rates significantly due to classification of equivocal results. Initially, when they did this, I thought that they were actually helping Roche to sell HER2. Equivocal HER2 results are also associated with larger tumor size, higher Ki67 index. So in practical terms, how do you do HER2 testing? Please, radio oncologists, kindly listen to this so that you don't be asking us to be doing immuno testing anyhow. Your newly diagnosed patients, you do HER2 testing alongside your ER/PR. If HER2 is positive, what you want to, of course, do is you give targeted therapy. And if there's no disease progression, that's all. If there's disease progression and patient has metastasis, you want to repeat the HER2 testing, right? Now, if you do HER2 testing and it's negative, you can't offer your patient targeted therapy. But there's disease progression with metastasis, then you need to repeat the HER2 testing. However, if there's no disease progression, you leave the patients alone. Now, if you have HER2 positive, you give targeted therapy. HER2 negative, you consider your treatment option. HER2 positive, targeted therapy again. And if it is negative, there's no need for targeted therapy. Still on protocol for testing for HER2, because I see that each individual radio oncologists decide on their own protocol. Or that's what I've observed. But I think there should be a standardized protocol in the country as to what is the treatment, what should we do when you have the immuno, and when did the patient get the immuno. So if you have sent in a core biopsy and the initial result was negative, HER2 was negative on core biopsy, and now you have sent in an excision specimen and you want to retest. If it is a grade 3 tumor and the initial HER2 on core was negative, then you must do the retest. If you have a small invasive tumor in the core that was grade 3 and it was negative, you should repeat it. If the resection has a high-grade tumor that is different from the core, you should repeat it. And if you suspect testing error, where you see that, oh, when you looked at the tissue or you looked at the slide, what the quality is for, then you want to repeat the tests. You want to repeat HER2. There's no need to retest if the initial was positive HER2 on a grade 1 tumor, particularly when you have ER positive, PR positive, whether it is invasive ductal or invasive lobular carcinoma. A grade 1 tumor, you don't need to do a retesting. Particularly, again, if over 90% is pure tubular, mucinous, cribriform, or adenoid carcinoma. This is why it is important to have that initial characterization of the tumor. Remember, I talked about tumor characteristics. What are the determinants of tumor characteristics? Histological type, tumor grade. So the type is very important. And there are instances where you have mixed variants in a particular tumor. If you have a mixed variant, you must talk about both of them in the histology report so that you see the reason why you need to test or you don't need to retest. Now, there's no need to retest when you have a grade 1 tumor and is initial negative HER2. And this is the variance that you have, whether it's purely tubular, mucinous, cribriform, or adenomycystic. I'm sure I will get comments from this particular slides. So how do you resolve the challenges in HER2 testing? I'm missing a slide. So okay, I just explained that the pictorial is what I just put here in the pros form. The negative HER2 test in core needle biopsy of primary cancer may be repeated on excision biopsy or excision specimen with histological discordance. You may repeat it if the histology does not correlate with the negative HER2 that you are seeing. And then, of course, you want to do HER2 testing on metastatic tumor. If there's HER2 positivity with histopathological discordance, you also want to repeat the HER2 testing. And then, of course, you have the local samples. What about ISH? ISH in HER2, that's in situ hybridization. Equivocal HER2 results are associated with larger tumor size and higher Ki67, which is the mitotic index. And Ki67 has clinical validity, but clinical utility is limited to stage 1 and stage 2 breast cancer. In prognostication alone, you can't use it for treatment. So when you say there's high proliferative rate, mitotic rate, you only limit it to stage 1 and stage 2, but it has no clinical utility. ISH is also used to establish HER2 status when immunohistochemistry is equivocal, or you can also do ISH alone if you have the facility for it. So breast cancer with more than one chromosome enumeration probe 17 have more copies of HER2 gene using ISH. How do you interpret ISH? Positive results, HER2, SEP2 ratio, SEP17 ratio of more than 2 or less than, or HER2 copy of number more than 6 is deemed to be positive. Equivocal result is when you have HER2 SEP17 ratio of between 2 and HER2 copy of between more than 4 and less than 6. Whereas negative result is a ratio of less than 2 and HER2 copy number of 4. You don't do ISH in Nigeria, but well, no, I think there's one lab in Lagos that is trying to do in situ hybridization. So, but we need to keep ourselves abreast of what is happening out there. Even our immuno is in Awilo, is staggering. So HER2 low breast cancer, again, what subsits for HER2 low subsits for ER. If we give you a result of HER2 low breast cancer, what are you going to do about it as a radio oncologist? And which are the HER2 low breast cancers? HER2 low breast cancers are those that when you do immunohistochemistry, HER2 is either +1 or +2. Before we just say is HER2, which is 1, is actually negative, and HER2, which is 2, is supposedly equivocal. But now we are classifying them as HER2 low. So 1+ and 2+ is HER2 low, and if ISH is negative. So approximately 50% of breast cancers will fall in this category. And the spectrum of breast cancers with varying, they are the ones with varying HER2 expression, this HER2 low breast disease. They have poorer prognosis compared to HER2 negative breast cancer. They often have higher histological grade, and they have higher proliferative index, and they are usually ER positive. Invariably, you also have a subset under the HER2 low breast cancer of HER2 heterogeneous tumor. These have larger tumors. They also have higher histological grades. They are more prone to nodal metastasis, less responsive to anti-HER2 targeted therapy. Still in reporting, because when you are reporting HER2, you are looking at the circumferential complete staining and the intensity of the staining. Now you can have incomplete circumferential faint in less than 10%, in more than 10%, in 35%. Each of these, the pathologist takes into consideration. But you must also remember that there are false positivity, false negativity, non-specific cytoplasmic reactivity, and tumor biology heterogeneity, whether it is focal or patchy reaction. So you see that the pathologist many times is struggling to make some interpretation of this immuno, particularly when you see that, oh, this patient has gone through so much. The patient has been waiting for the immuno. The tissue has not been properly fixed, and you are under tremendous pressure to just give a result. So these are the type of tissues you are getting that you struggle to make diagnosis of. You have HER2, this is HER2 staining, which is supposed to be, so the intensity of this is so strong that it looks like adire. And then this is beautiful ER, where you have the nucleus picking the stain. With this one, you struggle because a lot of background is there. And these are the ones that poor fixation has occurred in. This is also good ER. Now you have everywhere is brown. It's difficult to determine what is staining what. There's folding here, poorly fixed tissue, or you are using slides that are not charged. You have a lot of haziness here. This haziness is as a result of poor fixation. And you have a lot of background staining here. So what about programmed cell death ligand? That's the new kid on the block. And you have PD-1 is expressed on immune T cells. This PD-L1 is also known as CD274/B7. It controls T cell activation. PD-1 and PD-L1 are critical immune modulatory pathway with roles in maintenance of peripheral tolerance and immune escape in cancer cells. Its expression contributes to immune evasion, poor survival, and prognosis in breast cancer. And PD-L1 positivity, which is also membranous staining, like what you see with HER2, is useful for immunotherapy. Unlike HER2, though, it doesn't matter what it is staining, the intensity of the completeness. Whereas you want completeness and good intensity with HER2, as long as it peaks, they interpret this as positive. You also have to be able to score for PD-L1. And what are the cells that you score positivity? The immune cell score. It means that you're looking at all the immune cells, whether they are lymphocytes, macrophages, the cells within and around the tumor cells, and you give a scoring of less than 1, 1 to less than 5, more than 5, less than 10, and each of these has its relevance in advocating for immune therapy. So we talked about tumor characteristics as that what is most important is the tumor grade. Tumor grade is very important when you are looking at tumor characteristics. In pathological staging, when the surgeon accesses a mastectomy specimen, they don't even tell you whether this is anterior margin, posterior margin, inferior margin, superior margin, medial, deep. They just bring it. If you don't have marker, there are actually inks that you can ink in during the operation. In the absence of these tissue inks, one can use tag. Use one tag for inferior margin, 2 for superior as it's applicable, and that guides the pathologist. Sometimes the surgeons just take a chunk of fat because nobody's talking about sentinel lymph nodes anymore. But ideally, you should be talking about sentinel lymph node. So any lymph node that is okay. But because they feel that, oh, we are just saying something rubric, they just pick fat and send. Pathology searches, and then you process that labeled as lymph node, and it turns out to be fat. And you are hyperventilating that I send you lymph node. We don't eat the tissue. We're not eating tissues. So you determine immunohistochemical reactivity and then provide prognostic outcome. These three things will be able to assist the radio-oncologist in profiling proper treatment, and then you have a beautiful outcome for the patient. What should your pathology report be like? What report should the pathologist give you? What is the final report? We actually prepared a national template which was acceptable by all pathology departments in Nigeria. The problem was people were refusing to pay. Roche said they will pay, they are still not paid. The person that developed the template is still waiting for his payment to sure they are waiting for their money. But people are not keen on using this. And I think because we actually did some test running with the surgeons in Zaire, and it was a welcome idea for them, they wanted it. And I think they're using it in Lagos. If we have a uniform pathology report, what's happening? Is there a crisis center? Okay, so if we have a uniform template, then you don't need to be scrambling around that. Who made this report? Can I rely on this report? Because if you take... Can you mute your... Okay, so if there's a uniform template for everyone, then there won't be a problem as to acceptability of that report. Now, the final report should be synoptic, should be pros. All of this was taken care of that template that we developed. And every pathology report should have the histological type. You should grade it using the Nottingham grading system, or what you call as the SPR staging. You talk about the resection margin. If you have a mastectomy specimen, if there are lymph nodes, you should talk about the lymph node. If you have been able to access 5 lymph nodes, how many lymph nodes is showing tumor? If it's only one, then you say 1/5. If it's 3/5. If none is showing, none has lymph node involvement, what is the pathological stage? And that is determined in relation with the nodal status, and then the immune reactivity. Now, immune reactivity is not enough to just say ER positive, PR positive. You have to use the all-red score. Use the all-red score to give the clinicians an idea of what they are supposed to be doing, so that they will know whether the neoadjuvant therapy they want to give, whether the hormonal therapy they want to give is going to work or not. Even when we are seeing low ER, low PR, and low HU, we still need to talk about it. It's not left for them to know whether they are going to treat or not. So the caveat you put there is that you do not know whether endocrine therapy is going to be useful for this patient or not. So optimal diagnosis, can it be uniform and timely? And can we have full pathology report? So what about therapeutics in breast cancer? Prognostic, predictive, and clinical and pathologic features. We do know that triple negative are the most aggressive breast cancers, and they account for 15 to 20%, and they have 40% mortality rates 5 years post-diagnosis. They also have high metastatic incidence, low efficacy of current management protocol. They also have worse overall survival associated with positive expression of PD-L1. Whereas basal cell carcinoma type, basal type BCL, they express the highest level of PD-L1. So these are the ones I want to start thinking of immune therapy. PD-L1 testing for locally advanced triple negative breast cancer or metastatic. You want to do testing for them, particularly if you want to use this combination of drugs. For the unclassified normal-like breast cancer, there's no response to new adjuvant therapy. So this is the reason why we need to be able to handle our tissue properly so that we can have a beautiful immunohistochemical outcome. So what are my thoughts on breast cancer management? My own personal thoughts. The management decision, what is the management decision when you have intratumoral heterogeneity? When the histological grade type does not conform with the IHC outcome. What is the protocol for fluorid-DCIS? Do you advise the candidate patients to have mastectomy, or you just continue to do follow-up for them, even after you have done immuno for them? When should you repeat IHC? Because there are many instances where patient has had a true cut biopsy, patient has had immunohistochemistry done, and then you go to the radio oncologist, they are insisting on another immunohistochemistry. This patient has not accessed care in any way. So why are you repeating it? And of recent, I had cause to be hyperventilating about true cut of lymph node. Please don't send pathologists true cut of lymph node. You can have extra accessory breast in the axilla. The axillary tail can also be there. If you do a true cut, how do I know that is not the axillary tail of the breast? You need to give the complete lymph node with its capsule. Then we can tell you that, oh, this is a metastatic lesion or not. But shouting the pathologist that I've sent you 3/4 of the axilla and it is, you must tell me that it's lymph node, it's not going to work. You are only going to just be hyperventilating. Finally, I think I will rehash again that optimal diagnosis starts in the operating room, and you have ischemic time affecting the level macromolecules. When you don't fix the tissue, it has issues. Request for neutral buffered formalin. If you cannot get that, then get 10% formalin. Always measure the pH of your, insist that the pathologist should measure the pH and maintain it at 7.2. When your fixative is going low, please don't add water to it. Don't add Sprite. Don't put it in Zobo. Don't put it in bleach. Don't put it in soap. It affects the interpretation. So optimal diagnosis is a composite of clinical sample, tissue handling. Fixation is paramount, morphological analysis, and you want to have the Nottingham grading and the Nottingham prognostic index. And then you want to subject it to molecular interrogation. What you have is IHC. Every lab need not do IHC. You can send your specimen to where it is proficient, and you can actually ask that the slides can be sent back to you. This can also be done for radio oncologists, that if the patient comes and says, I've done this, you can actually write a request to that pathologist that, can you make your slides available? We also want our own pathologists to look at this slide and give us their own interpretation. More importantly, there must be clinical pathologic correlation with the tissue that you have worked with and the clinical information you have been given. And then I employ us to adopt the national template for pathology report. Thank you for your viewing attention. Thank you.
Thank you so very much, Prof, for the very detailed and extensive lecture. This is indeed a master class in breast cancer pathology. Thank you so much. Because time is fast spent, I will check the chat box for questions that have been submitted there. Kindly drop questions if you have any on the chat box, please. So there's a question here. Prof, Ma, can you hear me, Ma?
Yes, please. Yes, I can hear you.
Okay, so I have a question regarding changes in IHC status in patients who had true-cut biopsies and were initially positive for ERPR, had neoadjuvant chemotherapy, and later tested negative for ERPR, HER2, with mastectomy sample biopsies later on. A lot of oncologists find the disparity unsettling. Please kindly provide an explanation for such cases.
So I remember I talked about the smaller the sample, the higher the interpretational error. And I also gave a pictorial, a guide as to how you can repeat samples. It's not just enough to talk about IHC of true cut being different from the full specimen. What was the grade of the lesion in true cut? Because even with true cut, you cannot really fully grade the lesion because you're only seeing a part of the picture. You are not seeing the full picture. So grading of TrueCut also comes with its own challenges. So if the grade of the tumor is not, there's some discordance with the IHC result, then you should repeat the test. I was trying to go back to the slide, but I don't know, it's not moving.
Okay. Okay, the next question here is, please, why are ER negative, ER positive breast tumors considered insignificant?
Why are what?
Why are ER negative, ER positive breast tumors considered insignificant?
They're not insignificant, they are significant.
Thank you. The next question.
It's just the management now, is the drug now that, you know, that you have to know what to give them. They are not insignificant. There's no immuno outcome that is insignificant.
Yes, of course, because there are hormone therapies for those receptors.
Yes, there's none that is insignificant. No. What you can talk about is that the response, you may not be able to get full response, but it's just certainly not insignificant.
Okay, thank you, ma'am. Is in cases where a patient presents with HER2 positive disease via a TrueCut biopsy, gets neoadjuvant chemo/targeted therapy for about 5 courses before showing signs of disease progression, goes ahead to have a mastectomy and the IHC comes out to be triple negative. Do we associate this change to an initial wrong diagnosis or a change in tumor biology from the neoadjuvant chemotherapy?
More likely a change in tumor biology rather than a wrong diagnosis. Again, you remember that I said you must correlate the grade of the tumor with the IHC outcome. And if you've already given some neoadjuvant therapy, you should expect that it's going to change some things in the tumor biology. So you want to repeat. And I talked about tumor progression. If the disease is progressing, then you want to repeat your,
Yeah. Okay, thank you very much.
Last slide's up again for the person that is asking that question. If you've given targeted therapy and there's progression, then you want to repeat testing. Does not mean that the initial interrogation with IHC was wrong, but that now the tumor biology has changed. And that's why you now have that when this changes, when you now have, you retest and it's now negative, you now have to reconsider your treatment options.
Thank you very much. Another question here from Chigo. In the absence of FISH testing, what do we do for HER2 epifocal breast cancer?
So what we try to do now is to make sure that tissue fixation is optimal, and then we'll repeat the testing. But as I've said now, even before we have this lab in Lagos, we've been sending specimens outside the country to do FISH for them.
Okay. All right, thank you, Prof. Another question. I came across a histology with invasive carcinoma with choriocarcinomatous differentiation. Please, can you comment on that?
Choriocarcinomatous differentiation, but the bulk of it is invasive carcinoma. What it means is that for the treatment of this particular variant, it's not only enough to treat the invasive carcinoma, you must also add the treatment of choriocarcinoma to this variant. Remember earlier on I said that you can have a mixed histological picture in a particular tumor. Still talking about tumor heterogeneity, you can have just one, you can have tumor in both breasts, one invasive carcinoma, one is lobular, and in that lobular you have focus of medullary. And that's where treatment challenges come. So if you are just giving treatment for invasive carcinoma, what about the lobular components? What about the medullary component? So that's the same thing that you have. And the thing with tumor is we talk about tumor biology. Most cancers, the aim of every cancer is they want to differentiate. They want to be so well differentiated that they look better. Choliocarcinoma in the testis.
Yeah.
So but these are all, you start with immature cells. And when they become mature, this is the line that they want to take. And that's the best explanation I can give for this here.
Thank you very much, ma'am. The next question
So it's
is,
complete.
you discouraged true cuts of axillary lymph nodes and rather encouraged excision.
Your axillary true cut, for you to say yes, truly this is an axillary lymph node, you need to see the capsule. But for the FNAB, you are able to tell them, yes, there's a malignancy here. Now do what you want to do with the malignancy. You check it out, then we'll see. The
Very much,
FNAB can be done. And if people don't know, because when you do FNAB, the pathologist knows how he's going to smear that slide to get a rich outcome, and then how he's going to stain it. But you send me a slide that, many people just feel that once you get that smear, you just rub it around the slide and you send it. It's all a mess when it comes to pathology, and nobody can read anything there.
Okay, thank you, ma'am. The next question here is it possible to have ER positive, HER2 positive, and ER negative for a sample?
Many times, yes, we see it.
Okay. Can the duration of fixation affect an IHC result? For instance, a patient has a histology report that is more than a year old in a different facility without immunohistochemistry testing, and the tissue block is requested for immunohistochemistry. Is it possible that because of the duration of storage, the sample can affect the immunohistochemistry?
Yes, yes. It can affect it, particularly as we've said that we don't even know, all of these are macromolecules that they deteriorate with time. It's already been out, even though it has been fixed, we don't know the nature of fixative that was used and how long it was used for. And even in processing, we don't know whether the tissue was cooked or the tissue was not cooked. When I say cooked, that's over processing.
Right.
So yes, it can affect. 1 year duration is actually a long time if it was not subject to special IHC.
Okay, thank you very much, Prof. Professor Durosimi Eti says that I agree with your suggestion that we must have a standard protocol for use in Nigeria. Siphon developed one some years ago, and I suggest our country improve on this if possible.
Thank you very much,
Additionally, can you please share your presentation with all participants? I have enjoyed and learned a lot from your lecture.
Thank you very much, sir.
Another question, Mark. Lots of questions. Does wide local excision require lymph node biopsy? And can two samples of right and left breast be submitted in the same container if tagged differently?
Certainly, as long as you identify them separately and you give detail, in your request, in the request form, you say left breast is tagged with so. This is long suture, short suture. Identify them as appropriate. You can put them in the same container, and as long as the container is big enough, wide bore, we can put our hand inside and bring it, and that it is sinking into, is well permeated by the fixative. Not that you are pushing them and lumping them together and there's not enough fixative there. Yes, you can, as long as you have identified them appropriately. So you can put them in a drum and bring to pathology.
Okay, thank you very much. I think that's the last question that I have in the chat box.
Thank you very much. So we'll call it a day.
Thank you so much, Prof.
Sorry, sir. I don't know. I got locked out. I started typing my question and you're already saying that's the last question.
Okay, please go ahead and ask your question.
Okay. Ma, thank you for the beautiful lecture. I got a little worried when you talked about the fixation, the optimal fixation time for the samples we're sending for immunohistochemistry, whether the hormone positive, hormone estrogen and all that, hertunium. Usually in our center, I'm in Newi, so our samples most times the pathologists, the information we have is that they send it to Abuja or Ibadan, and in so many other places around us. So, and then the samples that are sent are the same ones that you send to the lab. If you also take a sample that you want to do histology, we don't request for immunohistochemistry, right? So it goes for histology. They comes back and tells you, oh, this is malignant. And then you also request for immunohistochemistry. Sometimes that takes some time. It takes a week or more. And then to send the sample now to maybe the tissue block to Abuja or Ibadan to now get immunohistochemistry, it takes another 2-3 weeks. I don't know. Does it mean what we're getting is actually not correct or?
No, it's very correct. When you've already processed the tissue, it's now in the tissue block. The tissue block has no issues as long as the correct fixative has been used ab initio. You can send the tissue block. The most important take home that I want everyone to have is that use the correct fixative and don't fix for less than 6 hours. Don't fix for less than 6 hours and use the correct fixative. I hope that helps. But many times when your pathologist will have reported the histology, is the tissue block that the patient is sending to the center where immunohistochemistry is done. So the patient goes with the tissue block. The problem that comes from that is when the patient goes to another center and the center says, this tissue block you have brought is not representative. I cannot see cancer here. That's where problems start. So it means that it's either the patient is being told, go and bring the tissue or go and bring more representative blood. So it's always good that when you are sending for immuno, request the pathologist to also still look at the tissue block, the slide again, select the proper tissue block that is supposed to be used for immunohistochemistry, because the tissue block that should be used for immunohistochemistry should have the tumor in place. If there's no tumor there, you are going to be wasting reagent for immunohistochemistry. We've seen a number of tissue blocks that they'll say, do immunohistochemistry, and we're looking for the tumor. We cannot see the tumor. So why do you want to do immunohistochemistry when there is no tumor? So we end up calling colleagues, we end up telling the physician, we end up calling patients that, can you tell them that we cannot see tumor here? And that should not be. So the first step is make sure you are sending the correct tissue block for immunohistochemistry. The tissue block you are sending has tumor in it, and then immunohistochemistry can be done. Is when there's no tissue, there's no tumor there, then that's what the problem is. But the important thing is fix the tissue properly. Whether you are in a private setting, use 10% neutral buffered formalin. Don't add water to it. And as soon as you are removing that tissue specimen from the patient, put it in formalin. Please don't give it to patients' relatives to go and bury. Don't tell them if they are going to go and bury the devil that has entered the woman. No, there's no devil there. The devil is when you do not tell the patient the right things to do. Thank you. I hope that answers you, sir.
Thank you, Prof. There is a last question. The question reads, how common is triple positive breast cancer?
Oh, it's the commonest that we see. It's the commonest amongst Black African women. It has a higher percentage. We've done quite a number of studies on triple negative. As a matter of fact, studies were also done that is triple negative that high amongst Black Africans, or is it a function of fixation? Fixation contributed, but triple negative is the highest that we're going to come across in our own searching.
Thank you so very much for the very engaging, very elaborate presentation, Prof. This is to remind all of us that the next session of this series is titled Multidisciplinary Team Management in Breast Cancer, Promoting Inclusive Management for Better Outcome. On this panel, there will be a representative of other key stakeholders in management of breast cancer, and we would like your contribution in line with your specialty. The session will be a virtual session on the 19th of June. And the time allotted for the panel discussion is 25 minutes, after which questions and contributions will be taken from the virtual audience. Relevant, tailored questions to guide the panel discussions will be communicated in due time. I'd like to use this opportunity to thank everyone for participating, Professor Samaila for dedicating your time and resources. And thank you so much. Thank you.
All right, good night, thank you.
Good night.
Good night. Good night, everyone.
Thank you, Prof.
Well done, Prof.
Thank you.
Well done,
Thank you very much, Prof.
Thank
Thank
you so much.
you.
Good night, everyone.
And to the moderator
Good night,
too.
everyone.
Good job. Really
Bye.
appreciate it.
Thank you, ma.
God bless you.
Thank you.
I mean,
you
take
too.
care.
Dr. Adebo, good evening. How are you doing?
Prof, well done. Well done, Prof.